Hi, and welcome back to Two Guys in Scrubs. We are Two Guys in Scrubs. I'm Silas Rades.
And I'm Delbert Yip. We're second-year medical students at the University of British Columbia, and we started this podcast to share what it's like going through medical school, discuss medicine, and pretty much anything else.
Please be advised that Two Guys in Scrubs is for educational and entertainment purposes only, and the views expressed do not reflect the views of our program or our supervisors. And welcome back. It has been a while, Delbert, my friend.
Yes, it has, and many changes to both medical school and, our lives as a result of that.
Do you care to elaborate?
Well, first of all, clerkship has been an absolute, it's been an absolute blur in a way, because at least for me, I started off in a subspecialty, and the level of complexity and knowledge was just completely outside the realm of my expectations. I was doing pediatric cardiology, and I was looking at echo and ECGs for every single child, and there was like more than 10 patients to see every day. So just very, very beyond my expectation and very fast paced. Did not expect that. And then now I'm in just general inpatient pediatrics, which is a little more slower paced, more like CTU, but then you get more diversity compared to the subspecialty.
Well, that sounds amazing. I really want to hear more details about it, but we can take just a really brief step back first and orient our listeners. Some of our listeners will be totally familiar with what clerkship is. Some will not. So I guess the last time we spoke, we had a great interview with Dr. Larry Chapman. At the time, we were still second-year medical students.
Yes.
And even we discussed on that podcast the fact that we would be starting third year soon, and he actually gave us some great advice as we start in Canada, what's called clerkship. And it varies depending on what country you're in. And I was also talking to a fellow from London, England, recently on my rotation. We were talking about some of these differences. But basically in Canada, we apply to medical school after either having a degree already or at least most of a degree. And it's 4 years, first 2 years preclinical, a lot of didactic classroom kind of learning. Once you get to third year, that's out. You're out of the classroom, very minimal to no didactic anymore, and you're kind of doing a practicum. In Canada, it's called clerkship. So we become clerks, as it were. And we just rotate through various specialties, predefined kind of tracks, and kind of spend a certain period of time with a team in that specialty and in a certain hospital or outpatient kind of clinic. So that's what Delbert and I are doing at the moment. And as you can imagine, it's a huge change from kind of preclinical classroom learning to all of a sudden being thrust into actually being a part of a medical team and being involved in patient care, even if nothing we're doing is super consequential. We're still, we're out there making an impact, making a difference, and it can be a total like deer in headlights experience, as it kind of you're alluding to. So why don't we start with your first rotation? Maybe we could get into it more because I'm really curious to hear, and then I'll share a little bit about what I was doing. So your pediatric cardiology was your first rotation.
Yep. That was at
where
BC
were you doing
Children's, and that's our only, I think, tertiary medical center for pediatrics here in BC. So we see lots and lots of different cases from everywhere across the province, and lots of complexity, as you might imagine, with pediatrics. A lot of rare congenital conditions, and then of course a lot of social complexity that comes with having medically complex children. And so I can't get into the specifics, but lots of things about financial difficulties or substance problems, things like that, in addition to the very complex medical problems that these patients had. That was one of the main things that I took away, actually, because as I mentioned, the medical stuff was really quite beyond my level of understanding. But seeing how the pediatricians dealt with and navigated these social complexities was really quite eye-opening sometimes.
Eye-opening, and I imagine to make a cheap pun, a bit heart-opening as well, I would hope. And
yes.
Is there any kind of de-anonymized single story that kind of that stuck with you, or something that a clinician might have said, or just how they dealt with a certain scenario that was really memorable?
I think talking about specific details is kind of risky in our situation because it's still so close to the actual case, right? So if we were to discuss something like a year later, it would not be as easily linked to what we actually saw. But I can talk about a case that's less sensitive. And this was a 17-year-old male who was presenting for follow-up of supraventricular tachycardia that was detected on ECG at a local ED that was relatively far away from Vancouver. And I just remember, because do you remember the operation that we do to quote unquote fix supraventricular tachycardias?
I would say, like, especially in a younger, healthy person, it involves some kind of ablation.
Yep, that's right. So the most common cause of supraventricular tachycardia in this demographic is going to be atrial ventricular reentrant tachycardia, or AVRT. Next most common would be AVNRT, which involves the AV node rather than a accessory pathway. So the catheter ablation procedure involves cauterizing the accessory pathway in AVRT, and it's very scary for anybody to go into any kind of operation. And the cardiologist, his way of explaining the operation, I thought was really nice, because the way he said it was, so the patient asked him, what are the risks? What are the potential complications, et cetera, et cetera. And the cardiologist was like, in my 25 or 30 years of doing these kinds of procedures, we've not had, any major complications. However, the way I approach every operation is that it is the most difficult operation that I've ever done. So I thought that was pretty, like, a nice way of explaining someone's, your mindset to a patient.
Yeah, and reassuring.
Exactly.
That's incredible. I love that, because one could be tempted also, like, from coming from a genuine place of wanting to be as honest and scientifically sound as possible. A clinician could approach that question as kind of just starting to cite the data. Oh, well, how risky is this procedure? And you immediately go to the the post-op complication retrospective data and say, well, there's a 1 in 5,000 chance of this. There's a 1 in 20,000 chance of that.
Yeah.
A 1 in 100 chance of that. And while you're being very honest and being scientifically sound and unbiased when you give that kind of answer, I think, for one, I would say general population, but even us, training in medicine, etc., sometimes it's hard to think in probabilities, and 1 in 5,000 compared to 1 in 20,000, 1 in 100,000, etc. It's difficult to build an intuition that translate those numbers into something that feels like more real and tangible. So I think that's one, and I think two, like, actually offering that more subjective point of view to the patient can be so useful. Like what I heard you said, it was both in that, hey, actually in our practice I've never seen it. So whether that some people might say, oh, well, that's of less value than citing like the larger multi-center or like international kind of risk data, but actually there's something to be said about citing just like the data from your actual center and say, actually, no, in our center we've never seen this.
Right.
And that makes it more real all of a sudden. And then two, to kind of give the patient an insight into your frame of mind as you enter the procedure, whether that might actually not affect the risk and the complication rate in the end, but to the patient, I think that's hugely valuable, and I personally would be very reassured hearing that, instead of a clinician was just like, well, it's 1 in 10,000 chance. Okay, see you later.
Yeah. Like, I feel it would be different. Let's say I was getting an appendectomy or something, and the surgeon told me, oh, I've done 1,000 of these. I think I'd be less reassured if he said that versus if he said what my preceptor said that day, which was, every operation I step into is the most difficult procedure that I've ever done.
Yeah, I think that's wonderful. And you know what? Since you said appendectomy,
You're right.
that's a great segue. Because I think I've texted you this already, but I'm sure you know that my first rotation that I did was general surgery,
Hmm.
and I did that at Vancouver General Hospital, which was, yeah, it was really quite exciting. It's one of the longer rotations that we have, 4 weeks. And as I understand, we actually get a little bit more surgical exposure in third year than some of the other medical schools in Canada. So I think that's great. I would say going in, what was I thinking? Well, going in, I think I was biased a little bit from things that I heard other medical students talk about, or just things that you hear in passing. And that was that general surgery actually gets kind of a bad rap, at least like informally.
Sure.
I would say people say, I would tell someone that, oh, they say, oh, what's your first rotation? And I would say, oh, general surgery, and they would kind of go, ooh, like I'd
Yeah.
get that kind of reaction. I was like, well, why? What's wrong? What should I be afraid? Should I be afraid right now? But I think it gets a reputation of being extremely difficult and demanding, like both in the hours and also just the environment that you're in. It can be quite high acuity, or at least like on the higher acuity side. Um, I think the staff gets a bit of a reputation of being intimidating or even mean, etc. So
Hmm.
you kind of hear these things. So going in, I was really expecting the worst. I was like, oh, I got to brace myself for impact. But I was actually very pleasantly surprised, and I had an extremely enjoyable and valuable rotation. So I had a great time, and so I'm gonna try and spread the word to other students that maybe you shouldn't be so afraid of general surgery. Um, let's see. So I was on the acute care service at Vancouver General Hospital. They have multiple teams. There's a trauma team. There's like multiple oncology teams. There's multiple acute care service teams. So it's quite a large service when it comes to surgery. And as most people know, general surgery, at least at VGH, it's quite focused on the abdomen. You have
Hmm.
neurosurgeon, cardiac, thoracic surgeon, gynae, urology, etc. Well, that kind of leaves the abdomen left, and maybe that's why it's called the general surgery. But I know in other places they also do thyroid, and I think they can do some other areas outside of the abdomen. But in VGH, the acute care service, it really is focused on the abdominal pathology. And yeah, I think what surprised me about it the most is how much medicine and kind of ward care and patient care was involved.
Mm.
I was expecting, okay, general surgery is just going to be a bunch of OR. Um, I'm not going to, there's going to be limited like ward medicine, etc. But then as I got into my first week and I started to experience what it's like, it's very, very multidimensional and very dynamic as a job. Like, yes, you're doing OR and you're doing cases, but you also have a large slate of patients on the ward that you are ultimately responsible for. They're admitted under your service, so you are well, not us, but someone on the
Yeah.
team is
Yeah.
the most responsible physician. It's not like in a minority of cases it is, but in the majority of our operating room cases, these patients are admitted in our service, and we are ultimately the ones that are responsible for their care, not just in the operating room, but pre-op and post-op, and we're also responsible for their discharge. So as you can imagine, there's a lot of medicine that needs to be done outside of the operating room to kind of care for these patients. Um, in a holistic way so that they're actually ready for discharge at the end. So I think that's something that I wasn't expecting. And if I just give you an idea of a typical day, we'd come to the hospital and I would usually get there around 5:30 in the morning, so quite early. But you get used to it. And first thing you do, you get there, you find a computer, and you kind of see your list. You see who are the patients admitted under your service for the day, and you kind of pre-round on them. You try your best to kind of look at the chart for every patient, although maybe with a specific focus on the patients that you were asked to round on after the pre-rounding. So you would very kind of really quickly try, okay, what are the most recent labs? Have they had any new diagnostics? Are they slated for OR today? Et cetera, et cetera. What kind of diet are they on? And then you kind of try and make your notes, and then you'd hurry to go visit each patient. You do a check-in. How's it going? You do a little physical exam, and you have to round on every patient before 7 a.m. Kind of meeting with the whole surgery team. where the night team hands over the patients that we're seeing overnight to the day team, and people kind of brief and debrief. And we also get to hear from the other teams that you're not a part of, which was quite fascinating. And then after that, it's basically, the day is starts at full speed. If you're on what's called an intake day, then you're doing OR all day, but also consults. So the intake, those days are quite intense because your team is responsible for holding the pagers, answering all the consults and the calls that come in for the pager. That's consults from the emergency department, where the emergency room docs think that there's a patient who might need surgery. That's consults from patients who are already admitted in the hospital on other wards, where a potential abdominal surgical concern has arose during the patient's stay for another reason. And you also get all the pages from the wards of patients that are already admitted out of the service, where the nurses or other staff might have concerns or questions. Are we going to change this person's diet? Yes or no? Or this patient is, the blood pressure is tanking. What do we do? Et cetera, et cetera. So not only are you responsible for managing all those consults and going to see patients in the emergency room, et cetera, but your team is also doing OR cases all day. So it's extremely, extremely dynamic. And you almost don't have a chance to catch your breath before and next thing you know, the day is over. So I think that's maybe some part of what people are alluding to when they say that it's very hard work and it can be exhausting, because on days like that you don't even have a time to stop and take a breath. It seems like things are just happening. But I personally love the action. It's like there's almost no downtime. You're constantly working, and it's super cool. I'll finish with this one story. I think it was maybe near the end of my first week, but it was an intake day, and I had been running down to the emergency department to see multiple consults, and there was this one case of a younger gentleman who needed his gallbladder removed, a cholecystectomy, and he was also presenting with a neurodevelopmental condition. He was there with his dad. And it was very, seeing the relationship was very sweet, but we were able to consult, we were able to get him into the OR. They did his gallbladder. I was able to be scrubbed in and present for the operation. It went really well. Then he went to post-surgery care, went to the PACU unit, and we did a few more cases. And just as the day's wrapping up, you're trying to finish notes, you're in the post-operative care area. And I just looked around me and I saw so much going on, and I all of a sudden felt like I was in some kind of medical TV show. I saw a patient going, on the stretcher, being rolled into the operating room area, who's about to have a surgery. I see the young gentleman, giving his dad a hug, who was about to leave the hospital after we did his gallbladder. They were kind of hugging and about to leave. You see another one of your patients who is just being rolled in after surgery. You just see so much going on around you, and you feel like you're in some way, actually contributing and responsible for what's going on. And it was just kind of an interesting moment where kind of like time seemed to slow down, and I just felt like I was in, some kind of TV show, and it was actually quite exciting. So that's some initial thoughts on my first rotation.
That's cool. I recently heard from a physician who was interviewing for his palliative specialty or certification. I'm not sure what it's called. And one of the interview questions he had was, how do you feel when you sit with patients? And then he reflected on his experience in residency and clerkship training, and he realized that he had never actually had the time to sit down or stand still and actually think about patients, because he was always thinking about the next consult or writing the letters or, consulting this and that. And it sounds like you spontaneously had that kind of reaction where you realized that, what was going on around you, even though you were probably caught up in all this chaos. And it reminds me of so especially on call in pediatrics, we help out with 3 different services. There's the maternal birthing unit, which is basically just checking up on babies who might have a need for resuscitation. And then there's the pediatric emergency. And then, of course, there's the inpatient pediatrics ward. And so oftentimes on call, we are running between these 3 locations. And especially in the ED, everything is happening so quickly and things are moving very, very fast. And sometimes you don't know where things are going because, well, to give some context, I'm currently at Surrey for inpatient pediatrics, which is a very busy location. And, I feel like there is really little time that people give you. There's no structured time, absolutely, to take a break and reflect on things. And you just always feel like you're on the go. But I think maybe that's why we have a little extra time to ourselves to maybe write some notes and so on. And that's been what I use, I think, to reflect on the cases and see what I might have done differently.
Yeah, absolutely. Hey, I was I was curious about one thing, which is it's possible that it's possible that some of our audience has become either aspiring medical students or
Yes.
medical students who are in first or second year who might be thinking about clerkship and or might be soon on their horizon. And although we are very green to clerkship, we're only 6 weeks in or whatever we are. I was wondering, what strategies have you developed, or which strategies have you devised, in the last 6 weeks, that have allowed you to be more productive, more efficient, more useful, etc. And things that you're doing now after 6 weeks that you weren't doing in the first week, and maybe if you could share, so what some of those were, and then I'll go next. Assuming there was, or maybe you just either you started maximally efficient, or you started not efficient and you haven't learned anything yet. So.
Okay. Yeah. I think I am more close to the latter, unfortunately, and part of it is because of the change in environment. Going from a subspecialty, very focused area to a very broad area was quite jarring for me. So initially in the pediatric cardiology service, you only think about the heart, really, right? So I got very good at the cardiac exam for kids, and I got decently good at reading ECGs, and I learned a tiny bit about reading echoes. And then I moved into inpatient pediatrics, where suddenly you're hit with the gamut of pathology, whether that's infection, RESP, endocrine, and of course, like perinatal complications. So for my first 3 weeks in pediatric cardiology, one thing that I found that was very helpful is just not necessarily forgetting about all the cardiac stuff, but focusing on it, really, really honing in onto it and learning what would the attendings need to hear. Because a lot of these patients, they're not new patients. These are often, because it's an outpatient clinic, these are patients that they've known for maybe a couple years or since birth even, and then they received some sort of operation or they had a congenital anomaly that was detected at birth, and so they're just following up on it. So learning about the details of each of the operations and conditions and what exactly the attendings would need to know at this particular time, given the natural history of their condition or the post-operative state, that was one of the major learning points I had. So for instance, if somebody's had tetralogy of Fallot, and they had repair for that condition, let's say 2 or 3 years post-op, what are the things that I should expect to see on physical exam or on their study investigations, and what would be the red flags? So for instance, we often expect a low SpO2 for these people. So if the patients or the family is reporting that last week they went to the pediatrician's office and they suddenly saw a high SpO2, that would probably raise some alarm bells or something that needs to be investigated further. In terms of things that are more useful in general, I think just learning how to summarize your case succinctly is extremely important. And I think that's even more so for surgery than for inpatient medicine. And I'll give you an example. Last week, when we were doing rounds, my attending didn't let me do a single case presentation in full. That is from ID statement to today's labs and imaging and so on. All he wanted every single time was give me a 2 to 3 sentence summary of the case so far. And I think that was really helpful, but it was also really challenging. And I think that's one of the main things that I keep needing to remind myself to think of like, one, why is this person here? Why were they admitted? Two, why are they still here? And then three, what are we going to do for them today? And that third step is actually the most important thing I think that I'm learning in these 6 weeks. Like, yes, we can generate the differential. Yes, we can understand the pathophysiology and, you know, what to rule in, rule out in terms of the differential. But what are we going to do for them today, and what is keeping them in hospital versus, you know, can they do something outpatient instead? Yeah. Sorry, I'm just
Yeah, I think that's
rambling.
wonderful. No, that's not at all. I think that's wonderful. And yeah, each one of those is really good learning points. I think, you know, what you're describing really is the difference between being at our level and practicing for 10 years, both in anticipating and knowing what your colleagues, regardless of what specialty they're in, care about the most in terms of what they want to hear about the case, and also, you know, what is the plan? What is the plan today? Because, you know, when our level, we've been trained and we're very good. Well, I don't know about very good, but let's say we're decently good
We're used
at
to.
being kind of like, yeah, we're decently competent at collecting information. You know, so we've been trained in our first 2 years.
Mhm.
First of all, like how to build rapport with a patient, how to communicate professionally and empathetically, and what kind of information should be collected, whether that be on, you know, history and physical exam mainly, and now kind of going into charts and labs and diagnostics. But, you know, most of us are good at going in, seeing a patient, and trying to, you know, just getting the full history in a structured way. Doing a physical exam, you know, and gathering the results of that physical exam, and then kind of just repeating what we found. But what we're quite good at is giving the long narrative form of everything that we collected. But we are not. What we are in our infancy is like how to take all that information that you gathered, which can be a lot of information, and tailoring it to be delivered to different scenarios. Whether that's, you know, you're running into your attending and they want to hear a 3-sentence version, which is like, this is why they're here, this is why they're still here, and this is what we're doing today. Here's my plan. Boom. Okay, great. Now, you know, I'm running down the hallway. Whether it's to another specialty that actually is going to care about, it could be caring about completely different information than you're attending, just given their different role in the patient's care. Or whether that's going to be in some kind of discharge summary where now you actually have to include more of the information and more of the background. So, you know, as we get better, I think it's going to be a huge skill to be, okay, you have this whole patient's chart in your head. And depending on the situation, you need to think to yourself, okay, how should I deliver and synthesize the information that I have? And which should I include? What should I not include? And, you know, you feel those skills starting to improve already, like slowly after 6 weeks. But I think that's really differentiates us from you know, actual staff and actual clinicians. And it reminded me of something that we were talking about in the last episode with Dr. Chapman, which was that he said that one of the utilities of doing this kind of clerkship type rotation and spending time within the various specialties and the various disciplines, even if you're not going to do that, even if you're not going to do that discipline, and even if you're not going to do anything that's remotely even close, is that your colleagues are going to necessarily be people from all the various specialties anyways, and kind of knowing how each specialty kind of thinks, so to speak, and knowing what each specialty cares about compared to others will really help you in the future, even if you're doing something that's very remote from someone else. Kind of having spent time with their service, at least for a time, will help you communicate more effectively in the future with those people. I think it's really interesting. And yeah, so much what you said is so relatable. Like I remember once we were doing, it was on my last week of general surgery, and we're kind of doing after handover, which I described. Then we kind of go to the cafeteria and we kind of meet just with our small team, and we run the list. We go down top from bottom of all the patients that are on our list, and kind of we discuss with the staff exactly like what you said. Why is the patient here? Why are they still here? and what are we going to do? What's their plan for today? Are they going for surgery? Are we discharging them? Are they waiting? Etc. And in the previous few weeks, like I had participated a little bit with this process, but usually it's the chief resident or the senior resident who's giving these summaries. But when I'd done it in the past, I was kind of allowed to give a lot longer spiels about each patient. But with the attending, just so happened in the last week, I started to give this longer case presentation, and she's like, no, 2 sentences. And I was kind of taken back, and I was like, oh my God, okay, 2 sentences. And then so I had to like immediately just adjust on the spot. And for the remaining patients on the list, I had to try and give that 2 or 3 sentence statement.
Yeah.
And and then, you might have to do that at the time. And then 10 minutes later, you might be discussing with the resident. They're like, hey, and now you have to present it again. But now I want 3 paragraphs. Okay, now you're writing a discharge summary. Now I want a page or whatever it is. So you constantly just have to be adapting the information to the scenario, which takes time. But I think a useful exercise, now that I'm thinking of it, like in the first 2 years, if people are preparing for clerkship or something that we could have done, or even something that we could continue to do, is take a whole case summary, the full history, full physical exam, everything, and then kind of prompt yourself to have to deliver it in like 10 different ways.
Mm-hmm.
So it's like, okay, this is how I would deliver it if it was 3 sentences to a cardiology attending. Okay, this is how I would present it if I was giving a case summary at a conference, or like, et cetera, et cetera. And if you just practice, I think practicing that in real time could be a potential useful exercise.
Yep. In fact, because of my experience last week in rounds, every single time I didn't get to do a case presentation, just 2 sentences, just 3 sentences, whatever. I'm doing exactly what you just said. Like for every case I see, after the day, I'll write down a 1-sentence version, a 2 sentences, up to 5 sentences, because I can easily do the full case presentation because we know the charts so well after, rounding on them. But it's the synthesis and almost the sense of paralysis you get when the attending's like, no, I don't care. No, skip ahead, blah, blah, blah. Which is a little nerve-wracking. But if you have it prepared or you've gone used to it, as you say, then I think it'll be maybe an easier transition for our junior colleagues.
Yeah, I think that would be a great exercise. And it also reminds me of the first week when I was on general surgery, and I'm finished now, but it's 4 weeks. So, and each week it's a different staff. The first week, and each staff might want, each staff kind of likes something different when it comes to case presentation or like delivering, the summary from a consult that you've just seen in the emergency department. On the first week, the staff really, really, really cared about us making an assessment and proposing a plan, with the caveat of knowing that there's a good chance your plan will be wrong, or it's okay if you say that they should have surgery, but we decide not to. But the point was, if you don't practice taking the exercise from the beginning to the end, which we haven't done very much in the first 2 years of school, where we were good at gathering the information and kind of delivering it up to the point of like making a differential, and then we basically stop. But now it's like, okay, no more differential. I want your assessment. You say at the end, you do a summary, and you say this is a so-and-so-year-old female, and she has this. Like, commit. You have to commit. And therefore, we will remove her appendix today. And it was very hard to have to force myself to try and take it to the end when you're so unsure.
Yeah.
But just based on your level of experience, you're so unsure. But so I actually really appreciated that exercise where the attending made us say something confidently at the end, even if we were totally not confident about it. Because he said, if you don't practice this, you'll never be able to develop the skill, even if it's out of your reach at the moment. You need to practice going beyond the differential. Because I think building a broad differential is an amazing exercise, and it requires a lot of knowledge. You have to know a larger breadth of all the things that this could be. But there's a certain comfort in doing that because you don't have to commit to anything. Oh, it could be this, it could be that, it could be that. And you're right, but you have to take the exercise further and go to the end. And then the next week, I had a completely different attending who really cared about the absolute, like fundamentals in the classical sense of taking a good history, and cared and wanted a differential at the end, but didn't care as much about assessment and plan because they said you guys are just not there yet. So you kind of take away from your various preceptors. You take away, you glean what you can, and you learn whatever you can from their approach. And none of them are right or wrong, but having a diversity of preceptors will develop you in different ways. So, for example, the second one, they were really, really adamant on not missing things such as the review of systems. In a history, this can be skipped over very easily, especially like in a surgical context. Now you're like, you did the consult. This patient has, very apparent, let's say appendicitis, CT confirmed. The chances of this being something else are very, very low at this point. Pre-test probability of appendicitis is like very high. But still, he wanted you to stop and go top to bottom. Any headaches, any dizziness, neurological problems, go down, any cough, whatever it may be. And you're like, okay, why am I doing this? But he brought up some really amazing examples of times where he had done this in his training, where they actually was able to discover and unearth some more insidious problems that wouldn't have otherwise been dealt with, which I thought was really cool. So he said, never underestimate the review of systems, which I thought was really cool and kind of more of a classical or a traditional approach to history taking. And it also just made me think. I had so many kind of golden moments along the way, watching the way that certain preceptors or staff did certain things, and just like very, very inspiring. Like you were saying, even something as small as, and I'll take it now because now I'm on anesthesia, which we get 2 weeks, which has been interesting. We can talk about it later if you want, but I just finished my first week. And even something as simple as it was a patient just from this week where, as they were being induced, as the hypnotic or as the anesthetic was taking effect, as they were falling in deeper into a general anesthesia, the preceptor would just go and hold the patient's hand, while the patient was just drifting off, and just little moments like that are very very inspiring, and you're gonna definitely collect in your pocketbook of experiences going through this kind of training.
I wonder if they were aware of that look, or if they were just simply measuring the pulse or something. You know what I mean?
Well, that's very cynical of you. Yeah, the med students like, wow, look at that. And then they're just feeling the pulse.
Yeah, rate, upstroke, amplitude, character, symmetric.
But no, actually, it's interesting that you say, are they aware of it? Because I had a very, philosophical question with one of the anesthesia staff.
Yeah,
who like really dropped a bomb on me when they said something like, at this stage of our understanding, when it comes to anesthesia, we're not really sure. Is the patient simply unaware of what's going on, or can they just not remember? And I was like, oh, that's deep. And my mind just started racing after that. All the implications of that. That's big implications of that statement. And even in like, what's the difference? Because like you're having all these, under general anesthetic, it blows my mind really to watch these operations that can be happening on people. Just with a simple drug or two or three, the patient is seemingly just completely unaware of what's going on, and we can make cuts and we can go do surgery on people, and when they regain consciousness, it's almost as if it never happened. Mm-hmm. And the question on whether or not that when they wake up, can they simply just not remember it happening, or were they unaware during the experience has important implications.
Yeah, I think it reminds me of, so even if somebody does not appear to have the same level of consciousness or cognitive abilities as we do, the way we treat them reflects on ourselves. In the sense of like, I don't know, if you believe we have a sense of humanity in interacting with other people. So, for instance, many medically complex children that I've seen over the last 5-6 weeks have severe cerebral palsy or had other conditions in which limit their ability to participate in the world as we do or as we can understand it. And it is very easy to go into the room and simply go in, check their vitals, do the physical exam, and not really interact with them in a quote-unquote human sense. But many of the nurses do on a regular basis, and I found that to form the foundation of how I interact with these patients, because even though they will probably never say hi or interact with me or return any of my gestures, I think it reflects on us as quote unquote normal people, if we do interact with them in a quote unquote normal sense.
Yeah, and I would add that we don't know what this person is experiencing.
Mm-hmm.
We can only infer, what people are experiencing based on how they interact with us, which, what we're used to, like you're saying with speech and body language or whatever it may be. But when those things are augmented based on a certain neurological state, or if you want to take cerebral palsy as an example, we still don't know ultimately what that person's inner experience is. And I think given that, we have the responsibility to treat them as such, or to treat them as if they're having a quote unquote more normal inner experience, because ultimately we don't know, and for us to therefore withdraw kind of our social engagement, I think is potentially doing them a disservice.
Mm-hmm. Silas, I've been wondering, with all these different experiences that we've had, have they influenced your interest in these different specialties?
Mm-hmm. I mean, I would say yes. I feel like I'm getting the feeling that after third year, I will be a lot less certain about what I want to do. Not that I am necessarily certain at the moment, but I think one of the plagues of being quite a curious person is that I really feel like after every specialty I do, I'm going to have the feeling like, all right, this is the one. because the experiences have just been so interesting in both. Like, well, okay, we need to have this discussion again, after 6 months and after a year, because I'm only on my second specialty. But I'm getting the feeling that like at the end, I'm going to be looking back and saying, I could really see myself doing this. Maybe not. Maybe there are going to be somewhere where I'm thinking, okay, there's no way I could do this. But at least so far, like I thought general surgery, like never. And then after the rotation, as you start to get the hang of it, and as you start to, build some small competency even, I think can be very motivating.
Mm-hmm.
And if you ask me now, like, could you see yourself doing general surgery or anesthesia for the rest of your life? I'd probably say yes, like both of them. I'm enjoying both of them already so much that I could see myself doing it. But I think what's important, and what the advice that's been given to me by preceptors that I've talked to, is that it is very important to consider lifestyle.
Mm-hmm.
And what your day to day, like, can you see yourself, can you really see yourself doing this day to day once the kind of allure of because like the initial learning curve on anything new is extremely exciting, because you're starting from zero, and that initial boost, that initial bump of knowledge can be very motivating, because you're just learning so much so quickly. But that's going to go away, like anything, and after years of doing it, the excitement in those small things are, it most likely going to go away after time. It's only natural.
Mm-hmm.
And then at that point, can you see yourself doing this job, on a daily basis? And also, I've been thinking about, and what is the rest of your life like while you're doing it? So I would maybe not talk about this in an interview setting, because it can maybe make you seem a little bit lazy. but you really need to be thinking, like, assumably there are things that you care about outside of medicine and outside your job. I'm making a lot of assumptions, but not all specialties are equal in terms of the time that they afford you outside of your job, to be putting time into other things that you care about. For example, for me, it would be family, or even certain hobbies that people have. People might love hiking or certain sports or spending time with family, or what they may have other volunteer or kind of initiatives that they're doing on the side. Like everyone in medical school has things that they care about that's not just medicine, although it's shocking to hear. Um, and for example, if I just look at or if I reflect back, if I look at my lifestyle during these various rotations, which I think for me, that's going to be what I'm really thinking about. I'm going to look back and I say, what was my life like during these experiences, and not just in the hospital, but like my entire life, what was it like? And if I think about on general surgery, my life was taken up like quite substantially by the job of general surgery. So I feel like I had very little bandwidth for other things, both because the hours are very demanding. Like I think I was, working 80-hour weeks, for example, but also because you have these patients that are on your service, under your care. Even if you're not the MRP, it's still that kind of feeling where you go to home at night, you're not leaving the job. You're thinking about the patients who are still under your care. You're thinking about, who you might be able to discharge tomorrow. You're worried about Mrs. So-and-so who's been bumped now 3 days in a row from having her MRCP, and you're frustrated about that, or whatever it may be. So I would say longer hours and harder to leave the job at the job site. You take more home with you. So if I think about my 4 weeks, I had a lot less time to kind of play with my infant son, to spend time with my wife, to go visit my mom, who lives outside the city. And compared to anesthesia now, which is, I'm working maybe 40-hour weeks, and I have time in the late afternoon, evenings to do something with my son, to take him to the swimming pool. I have weekends to go hiking and experience nature and be with my family and stuff. So although you wouldn't be talking about that in an interview, like, oh, I'm really choosing this specialty because I want to work the least amount possible. You would never say that, but I think it's important to consider like both what was my lifestyle like, and was it conducive to everything that I care about, and B, this is also something interesting that I was thinking about recently. I would want to hear your take, which is B, what kind of person did I feel like during that time? Because I think that, okay, our personality is more or less stable. We're not going to become completely different people depending on what service we're working on. But I think it does change a person in small ways. And I think that, being in general surgery compared to anesthesia for me is going to bring out different aspects of my personality. And so I'm going to be personally thinking, A, what was my entire lifestyle and life like during that time? And B, what kind of person did I feel like during those experiences? And did I like the attributes of my personality that it was bringing out? Yeah, that's where I'm at with it at the moment.
That's very comprehensive, and I think, in as you say, in 6 months or a year from now, we're obviously not going to remember these rotations as well as we do now, and so it would be valuable for us, I think, just to revisit these conversations at some point later. I'll go reflect in sort of the similar order as you did. So starting off with the things that I enjoyed and things I didn't really enjoy about pediatrics, the pros and cons. So pediatrics, some of the greatest things about pediatrics, I think, is obviously working with kids who are, for the most part, very resilient. You could miss something potentially and they could still get better on their own, or their natural history is just better than adults. And then kids are just nice and cute and fun to play around with. And furthermore, parents and families, for the vast majority of patients, they have the best interests of the patients in mind, and it's easier to advocate for them, I think. So the common misconception that I've heard is that people don't always like pediatrics because parents are hard to deal with. Yes, that's true in some cases, but in the vast majority of cases, the parents are your allies. They give you very good histories, and you just really come to appreciate the value they have in the whole, experience of pediatrics. The cons of pediatrics. So in any subspecialty, I imagine this is the same case for internal medicine, is that a lot of your life is sucked away from you as you train in this subspecialty. So for cardiology, many of our fellows were doing multiple days of call a week. They'd be called in to do echoes, interpret echoes, and then you have a challenging clinic schedule or a CTU schedule ahead of that. On top of that. And that takes many years of training. And then when you become an attending, things don't necessarily become that much easier either, because cardiology is also a procedural specialty. You have electrophysiology, you have catheter stuff. So it's not easy from a lifestyle point of view, nor an academic point of view. And you sort of have to really assess, as you say, the lifestyle as well as the academics. Cardiology is a very fast-moving field, as many people know. It publishes probably the highest volume of research out of all the internal medicine or medical specialties, just due to how common these pathologies are. And this brings me to perhaps one of the biggest pain points, I think, of any pediatric subspecialty, which is the lack of research or the lack of research funding. Many of the things that we do for children with these complex conditions are borrowed from adults, whether that is the procedures or the equipment themselves. And so it often feels like we're working in suboptimal conditions because we simply don't have the resources that to explore or to utilize to really treat these patients optimally. And that sometimes is a fairly depressing thing. In terms of, so the second thing you mentioned is sort of like the lifestyle. How do I see myself? Could I see myself doing pediatrics in the future? So I think the kind of person I became during pediatrics, or that I'm becoming, I think I'm becoming a somewhat more patient and nicer person, more tolerant of kids who are not great historians, who are very fussy and not cooperative most of the time. However, I am also not generally a very patient person. So this is sort of my upper limit of patience and tolerance for children, I think. And I also find that the level of social complexity in these cases is often a little higher than I personally would like. I like thinking about it, and I enjoy the opportunity to see it, but it's difficult for me. And I don't think I'm the type of person who could easily deal with this type of thing regularly. And I've only been on this service for 3 weeks now at SMH, Surrey Memorial. And already I think it does take a toll on me when I see these types of cases.
Yeah. Mm-hmm. And, I think those are exactly the kind of reflections that will lead you into making hopefully the right choice. Mm-hmm. When it comes to committing to something for the rest of your life.
Yeah.
I think it's exactly how you should be thinking. And I would encourage, people who are also going through this training to have a similar outlook. Yes, things like salary and, location where you might be living, they're important. But in the end, what kind of person is it pushing you to be, and is that congruent with who you'd like to see yourself being, or who you feel like, is maybe these social interactions are just making you look longingly towards the dark radiology lab, like, wow, that's my safe space.
Who knows? Maybe. All right. So I guess that's my reflection. Like, I've really enjoyed pediatrics, and it sounds like you've also really enjoyed parts of your general surgery with, as you say, golden moments for both of us. But there are pros and cons. And I bet, as I'm sure as we continue in our clerkship journeys, more and more of these insights will surface that we were never aware of.
Oh, absolutely. Either or don't remember.
That's true. Yes.
Yeah, but you know what? We'll try and revisit it more frequently, and for our listeners, we'll try to have some more fascinating guests on in the coming episodes, and we look forward to that. So I'll wrap us up, and that was Two Guys in Scrubs. If you want to support our podcast, leave us a like or review wherever you listen to your podcasts. Thanks for listening, and we'll see you next time. Let's jingle us away.
Jingle, 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 jingle.
Jingle, jingle.